Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on mentors and motivators who are consistently reshaping, redefining, and rediscovering the field of medical healthcare. We are happy to welcome Dr. Martin Miner, a prominent specialist in the field of men's health and celebrated clinician, academic, and researcher.
Thank you so much, Dr. Miner, for joining us. It is a privilege and an honor to have you here. If we can just reflect back to the early years and perhaps if you can discuss your initial motivation as to why you went into medicine.
I've been a physician for 34 years, and it was something I always wanted to do, and I always felt that it was such a gift to be able to share intimate details about people's lives and to try to help others and to listen to their stories. So it's always been that way. I was in the Indian Health Service for about 2 years, and then I was in the Public Health Service, and then I was private practice as a family physician for 23 years, and then I went into sexual medicine the last 17 years.
And what was the catalyst for you to transition into sexual
medicine? As a family doctor, I took a liking to older men who, it was before Viagra was released in 1997, and they just wanted to be able to function, not all the time and not like they did when they were in their 20s, but they just wanted to be able to be celebratory of anniversaries or birthdays or special moments in their lives as a couple. And that sense of masculinity.
Moments, right.
So, and they were open about that, and I liked that, and I wanted to do more in that.
So when you got into this type of medicine now, where you're focusing on men's health or sexual health, how was it that you identified hormone replacement therapy as being the drug of choice, so to speak, to help and assist your patients?
Well, it's not necessarily hormone therapy as the choice. I found that most men who I saw for sexual dysfunction had common themes. And those themes were that they had the comorbidities that are often associated with erectile dysfunction, specifically high blood pressure, obesity, type 2 diabetes. And they also had issues about their lifestyle. They weren't getting enough sleep, or it wasn't restful sleep. And many of them had sleep apnea that was undiagnosed. And all of those factors were also associated with testosterone deficiency. So testosterone, I always found, was a tool to try to get these men to change their lifestyles, to try to get them to exercise, to get them to diet, to get them to try to reinvigorate themselves and re-establish their goals in a more healthy fashion.
So in your talk today, I know that you spoke about how lifestyle changes can help with the overall functioning of this. So can you elaborate on that and talk to the diet and exercise and the protocol of Chinese medicine and how that comes into play in your practice?
Yeah. Well, I wish that Chinese medicine came into my practice more so, but working in the university, we've never been able to work along acupuncturists because we haven't been able to get them privileged at the hospital. So perhaps it'll be different in the future. But I find that every man that I see has a unique set of circumstances. Every man has a unique story. Many are thinking solely about providing for their families. They work 20 hours a day. They tend to be, several of them are type A individuals, and they don't really think about themselves. And things kind of creep up, whether it's their weight and this feeling, this sense of ill-being. And so it's really important, I think, for them to reestablish priorities that include exercise. And when you talk about exercise, it can be as simple as just going out and walking for 20 minutes briskly. I just try to get them to do it 10 minutes a day for the first month or so, just to do it and incorporate it into their lifestyle. For so many of them, it's such a hurdle to get to the gym, and then they have to shower, and then they have to bring another set of clothes. So at lunchtime, I just tell them to go out and walk briskly so they can't really talk to someone. And that's part of it. And eating clean and eating healthy is also something that's a learned behavior, and that's eating based on hunger and not necessarily based on desire, right?
So are there certain foods that one should limit or intake into their daily diet that would help to increase testosterone? Has there been any science on that?
No, that's a very good question, and I can see how eating a very poor diet can lower testosterone levels, because if you eat primarily carbs or sugars, you're going to quickly develop insulin resistance if you have a proclivity to develop insulin resistance. The idea of actually improving testosterone levels through diet, I don't think has been quite established, but I think it's pretty clear that if you exercise regularly, you're going to increase levels, although that too hasn't been well documented. It certainly has been documented that you can improve your sexual function, and that is vital and important to almost all men.
So in your practice, when somebody would say, I think, I may have low testosterone, and what were some of the things that they're experiencing at home in addition to low libido?
Well, I think that's the primary one that brings them in. Is it
their partner sending them in, or is it they sending them?
No, I think
taking
it's
the step, right?
Yeah, depending on where their partner is in life, I think that many women who are undergoing menopause also share a diminished libido for a time. But I think for men, it's their erectile dysfunction that brings them in, and it's there's a sense of virility and a sense of youthfulness and vigor that we all associate with morning erections, whether we use them or not, with our partners. It's just the fact that we're waking up with an erection that feels good, and it kind of reminds us of our adolescence and our youth.
So what myths have you personally been able to dispel surrounding testosterone therapy?
Myths of testosterone therapy.
And its association or lack thereof, with it's been talked about.
Right.
With prostate cancer and other.
Right. I think Dr. Morgenthaler has done a pretty good job of, in the last couple of decades, illustrating that testosterone deficiency and, that testosterone repletion is not associated with prostate cancer. Yet what's interesting is that all the guidelines, whether they're the AUA guidelines or the endocrine guidelines, have us following PSA and prostates, and just by the act of ordering PSAs, we're increasing surveillance of prostate cancer, and oftentimes I don't think testosterone causes prostate cancer, but we certainly uncover more cancers because we're drawing PSAs. But also, what I've truly learned is that the association of testosterone deficiency and obesity. I think almost all of the men I see have difficulty with their weight.
What's the typical age of your patient?
Well, it's much younger than I expected when I started, but
Wow.
probably in the late 40s and early 50s. And there's a period of time when we lose men to healthcare. It's probably from age 20 to age 40, when they don't go to the doctor, when they have young families and their primary responsibility is providing for their families. So they might have an insurance physical, but they don't really think a lot about their own health habits. And that's when things can kind of begin to go awry. And by the time they look up, it's almost like they're in the deep end of the pool and they're being enclosed by water that they...
You had mentioned, though, that your average patient age is younger than it was when you started. What do you attribute that to?
Because I think there's an epidemic of obesity. Just like there's an epidemic of type 2 diabetes related to obesity, all of the comorbidities that we see in the US, hypertension, dyslipidemia, which is elevated triglycerides, low HDL, these are all manifestations of genetics, but also of a poor lifestyle. And ultimately, their sexual function fails them and they come in.
So you were the recipient of the Massachusetts Medical Society's award in terms of achieving the most significant contribution to men's health. So what accomplishments do you feel that you have made in the field?
Well, the Men's Health Center in Brown at the Miriam was the first such center that opened in the country, and it was quite a great deal of work to try to convince people that there was a need and that it was necessary. I really don't think of myself as having made significant contributions because...
You seem like a very humble man.
Thanks, that's kind. But I feel that it's most of what I've learned from my patients and what I've learned from working with men over all these years. I love women and I understand the need for women's health, but I also truly enjoy explaining the physiology of the body, the physiology of erections to men, so they understand why things are going awry, specifically about performance anxiety and almost every...
You take away the fear and the psychological component of it out of their, out of their awareness.
Well, I've tried to actually make them mindful of it.
Well, but mindful that it's actually a physical situation. It's not coming from their...
Right. The trouble is that every man who has ED, almost every man has, whether it's vascular, predominantly vascular, they all develop issues of performance anxiety. Their libido goes down because they're failing. No one wants to do something that they consistently fail at, especially something that's so intimate as making love. And they become very focused on their erections. And as they become most focused on their erections, they become terribly focused on their penises and less focused on their partners and less focused on just the sensation of physical intimacy and closeness. So I try to teach them to try to restore that physical intimacy, to try to do sensate massage with their partners, to try to relax and breath exercises, things that I've learned in yoga classes. It's kind of an adventure and a lot of fun.
Let me ask you, though, with all of, between your practice and your teaching, how do you find that teaching has enriched your practice and your personal life?
Oh, it's restorative. It's, as I see residents and I see medical students, it doesn't feel that long ago that I was in their position, but it is. And there's just such an intuitive and creative sense of learning and a desire to learn. More so in the students, the medical students, than the residents, because by the time they're in residency, they're tired and they're, they just want to get through the elective. But the medical students are very excitable and teachable and appreciative of anything that they're taught. And I just remember being a student and not having someone really sit down and try to explain what they were doing with me, with patients. And it's wonderful that they have an exposure to patient care at such an early stage. Brown has a doctoring program where you're actually a mentor of a first-year medical student for an entire year, and they come spend a half a day with you, and they see you with patients, and then they spend time with that patient. And this is just beginning as they're learning the very basics of human anatomy and physiology.
So I know that in your practice you spend a good deal of time talking about prevention to your patients. Mm-hmm. Do you share that same knowledge with your residents?
I do. It's really important that they take care of themselves, that they eat, and those are things no one really stressed to me during
when you were in medical school.
When I was in medical school and residency, and no one really was concerned about how much I slept or what I ate. They used to have cold cuts every night in the cafeteria. When I think about it, that if you're on call every other night, that doesn't make for a very healthy lifestyle.
So what does that mean to you in regards to men's health and sexual health?
Well, it means that, first of all, accepting responsibility for your own health. We all like to be taken care of, but it kind of ends when we leave for college. And
will you tell my son that?
Yeah. That's a good example, because when, boys go to college, suddenly they have all of this time that's a lot of it's meant for studying, but a lot of it's free time because this is their sole job now. They're in school. And with that, many of them can develop very active social lives and a lot of partying, but it's really up to them to really
make wise choices
and to have good health habits. And these days in colleges, many colleges have just that, McDonald's and other fast food establishments where they can use their meal cards just as easily as getting something in the cafeterias. So they have so many more choices, and they always want something fast. And I understand the desire and the need to eat quickly and to make these choices, but overall they have to begin to become more mindful of just that, of getting good sleep, of still exercising. And I tried to impart that in my own sons, and it's a vital part of the counseling that I do with patients.
And now, if there was in fact a direct correlation between that McDonald's hamburger or that fried food and their testosterone level, perhaps, then maybe that would help to mitigate their consumption of these hormones.
There is actually a direct correlation between the hamburger and their erections, but I don't think they quite kind of realize that yet because of the fat intake and and it does. At that point in time, the endothelial function in their penises can withstand a lot of insult.
So is this specific to the 18 to 22-year-old?
Yeah,
okay.
Certainly smoking.
Wow.
And now there's a lot of the vaping, and there's actually been an increase among smoking among younger men, more men than women. But it's hard to believe. But it's kind of cool again. So
how do you determine whether or not a man is the right candidate for testosterone therapy? And at what point do you make that, even if they're testing for low testosterone? So
I don't treat numbers.
Okay.
So if they have low values, there's usually a reason. And I tell them this, and I say, part of my job is to figure out why your testosterone is low and to share that with you. You have to know why your levels are low. And together we're going to do that. So that's our first goal. And the second goal then is to clarify what clinical signs and symptoms they actually have, and which are going to would respond to testosterone repletion, and which of those won't. Because the expectations of everyone has different expectations of testosterone, and
you mean 24 hours later that pellet's not going to make it all better?
Yeah, or that suddenly they're going to
right.
develop a very muscular profile, and there's no need to do anything else. And then I also tell them that testosterone without exercise is really almost meaningless. Although I don't think everyone agrees with me about that, at least, but it's something I firmly believe. I think of testosterone as a tool to get men back onto a healthy lifestyle so that they can lose the weight that they need to lose, so they can exercise, so they can become motivated to take care of themselves. And my hope is that we can restore their endogenous testosterone, that we can restore their own levels. Depending on their age, that may or may not be true. But I don't think of testosterone for life. I think of it as hopefully something that that can be a tool that they can use to, like I said before, to reestablish themselves.
So what's the typical time span that somebody is on testosterone, typically?
Well, it's unique for every individual, but at least 2 years, 1 to 2 years. And then if they can lose that weight, it's kind of like bariatric surgery. When you see people get closer to an ideal body weight, their diabetes improves, their blood pressure improves, their lipids improve, they're off all these meds and they're astonished and they're so happy. And there's a pride and a sense of body image that makes them feel so much better about themselves. And I believe that not only makes them feel better about themselves, but it improves all their relationships with their partner, their relationships with their children. And
are there any negative effects of the testosterone?
Are there negative effects? Well, it needs to be monitored. So you need lab work pretty regularly, whether it's every 6 months or once a year if it's stable. But we have to monitor hemoglobins and hematocrits, although there's a controversy about that, about what's the risk of erythrocytosis. The belief is that potentially adverse cardiovascular events could be related to elevated hematocrits exceeding 54%. And I describe that to men as it's a measure of the viscosity of their blood, that if it's too thick, that may not be good. And there are many men who tell me that when they're on testosterone and they need to be phlebotomized because their hematocrits are close to 54%, that they feel much better after they've given blood. It's kind of an ancient medical treatment, bloodletting, but it's interesting.
So Dr. Miner, you said that you do have some patients that after 2 years they're able to get off of the testosterone. I know that that's a goal.
Right.
So what exactly happens in their body that enables that to happen?
Well, part of their fall in their levels to begin with is not just age-related, but it's related to the comorbid disease states that they develop as they age. For example, like developing hypertension and being treated with a med for hypertension, or developing dyslipidemia. Many of these things don't happen or don't occur to men until they're in their late 40s and early 50s. And as they do, that's when you see a drop in their testosterone. And whether or not, and this is part of what I said in the last talk, whether or not that's related to the disease states themselves or the testosterone dropping is unknown. It's just a bi-directional relationship. The point is that if men can make those choices and take control of their health, improving health, losing weight, exercising, and developing an improvement in all those metabolic parameters, then it's possible that their testosterone they can start their own endogenous production of testosterone again. I might, after 2 years of stop the testosterone or switch them to clomiphene citrate, an oral medication serum that we use 3 times a week to see if we can increase their own production of testosterone. And then after that, we can titrate that down and hopefully they can go off it. It's not something that happens with every man. In fact, it's often quite rare that they, especially in their 50s, that they start producing their own levels, but it's something that we can ascribe to.
So in the future of medicine, what changes do you anticipate or would you like to see in terms of the use of testosterone within the next 5 to 10 years?
I would hope it could be that we can, first of all, that we can document its safety. And I would hope that we could, as we're aging, if we're going to live into our 80s, we want to be mobile, we want to be able to hike, we want to be able to boat, we want to be able to play sports, we want to, and in order to do that, we want to make sure that we don't become frail old men. Testosterone can be a tool and can help us. I don't think the data is there to suggest that testosterone therapy reduces or improves what we describe as metabolic syndrome, improves blood pressure, improves insulin resistance. But part of me believes that intellectually that it does. And it hasn't been established, but that it does improve those parameters. And if indeed it does, then that's another tool to lessen disease, lessen the cost of care as we age, and improve our quality of lives. And if that's what we can do, I think that's something that's very positive.
You wonder if there's an association psychologically between the man's return of his virility and then his desire to go back to the gym, for his desire to eat better, for his desire to just make better lifestyle choices because of the positive therapeutic benefits that the testosterone is happening. And thus, the end result of that is because they're making the better lifestyle choices, they're having a reduction in their numbers and their...
Exactly.
So I'm sure it's working, in tandem.
And I think that, that is kind of the psychological connection that I try to tap into. That, we all feel better when we feel that we're men. And it's not about being macho, it's just about being comfortable with our sexuality, being comfortable with who we are, being confident in our choices, as you said, and being attentive to those we love and those who love us and our abilities to take care of ourselves.
You are you appear to be an extremely compassionate and sensitive man, physician. Your patients must feel a tremendous affinity towards you to be able to have such sensitive conversations and discussions. You exude this incredible inspirational passion for what you do and for being able to bring that and restoring one's, sense of manhood. And so I think it's important to note that it's it's a rare it's rare amongst physicians to see that kind of compassion. And
I really feel very lucky and fortunate to be doing what I'm doing, and I learn as much from my patients as hopefully that they learn from me. It's something that goes both ways. It really does.
Well, you have to be an extraordinary role model, though, for those that you teach, and both the residents and those in medical school that you're teaching, because there's no ego here. Like your ego seems like you left it out the door. And
will you tell my wife that?
Yeah. Anyway, my final question for you is, so what do you think are some of the main challenges that you are faced with in regard to treating your patients with the appropriate preventative or restorative methods?
Well, the main challenge is time and resources. I'd love to have access to a nutritionist because my knowledge of nutrition is just to stay in the periphery of the...
You have Dr. Flynn.
I know, she's wonderful. But she's really busy. And also... I'm
sure she'll make time for you, Dr. Miner.
Yeah, she's wonderful. My knowledge, I didn't learn much about nutrition in medical school. I didn't, and I didn't learn how to cook healthy. And so it's all been kind of knowledge that I've tried to acquire. But I'd love to have someone who's able to sit down and work with these men, and also like to teach men how to resume exercise. Many of these men haven't exercised in 20 years. And when they go out, they're going to hurt themselves. So it's just important. That's why the walking is important. It's just important to start moving.
So they can start moving.
Yeah, so they can start moving, yeah.
Well, thank you for your time, Dr. Miner.
It's been a pleasure. It's been nice. Thank you.